There's this, Roosevelt County is considered medically underserved. This health professional shortage area is a designation, it's a score of 0 to 100. 0 is there are no professionals, 100 is all of the professionals in the world live in this city. We are 15. So, we are definitely medically underserved. There's not a lot of resources here. Another thing to look at is the ratio of primary care physicians to patients. In Roosevelt County, it's 1 doc to every 1,700 people. And even New Mexico as a state has a very high ratio compared to the nation, but it's still a lot better. You can imagine in like Albuquerque and the bigger cities to have more docs available. So I looked at, I have to explain why I want to focus on diabetes, and then I looked at the resources that are available. So if you are a patient in Roosevelt County, what is available to you? And actually, this is really cool, this Echo Endo project. You've probably heard of it. On the floor, we've probably referred patients to the Echo, the psychiatric services with Eva. But we have Milu in the clinic who works with doctors, specialists from UNM in Albuquerque and then New York University. And also she has, oh my gosh, I always forget, Rafaela, who is the community health worker who is bilingual. And she works as a community health worker to follow up with them on their blood sugars, healthy eating, activity level, so on and so forth. But you can see those are only 2 people, and they offer appointments Tuesdays and Thursdays from 9 to 12. So something we can do on the floor would be to, see if they're interested, maybe get them referrals to that program. There are pamphlets in the clinic for this, and I can see about getting some of those. If you are interested in giving them out to your patients, I can look into that. But it's really cool. They use telehealth, so it's pretty thorough. It's a good program for not having a lot of resources. They do a good job. It's pretty comprehensive. Here it is on this is on the website. We did have a little video. That's Milu, Rafaela. They have other services too. Not just diabetes, it's all of endocrinology. Okay. So the next resource that I found was a class, and it's actually offered across town at La Casa, and it's called My Chronic Disease. They offer it, this is the English version. In Spanish they have Tomando La Salud. It's a 6-week course. Each session, there's a session per week, and it's 2.5 hours long. They just brought it to Roosevelt County and Curry County up in Clovis this fall. It's a class out of Stanford University, and this has been in the research since the 90s. Like, they've done a lot of studies on it. Let's see. It was at the senior center, and if you had any chronic disease, if you had arthritis, asthma, diabetes, hypertension, anything like that, they were referred to the program from their La Casa clinic. Their friends and family were encouraged to come to learn along with them. It was pretty cool. They gave out this textbook, and then they also gave out 2 different CDs for like relaxation techniques. So they focused on everything. Problem solving, mind, body, positive thinking. It wasn't just eat your vegetables and there you go. It was a cool class. But as you can see, it's very generic. It's not specific to diabetes. There was a study though that said this class would be a good help patients with type 2 diabetes. So it does show that it can lower hemoglobin hemoglobin, A1C, and some different measures. Insulin dependent diabetics, they would need obviously more thorough education than this. This would not cut it. That's it. Like, that's all that's offered. So if you're in a big city, you probably have a whole entire clinic that is designated to diabetes education. And in Roosevelt County, that's what we have. So that's where we come in, is we're in the hospital. We are another point of contact for the patients. In a town like this where there's just not a lot, even if you have a great program like ECHO, you're talking Tuesdays and Thursdays, and we said 3,000 patients. It's not, we can't serve that many patients. So we have to look at the resources that we already have, and we are a huge resource, the hospital and the nursing staff in the hospital. So kind of the major point of this is to see if there are things that we can change at the bedside while they're inpatient to improve care for these patients while they're here. Hopefully keep them out of the hospital, help them with behavior changes, and we'll go through all that. So, let me make sure I went over. Yeah, I looked at, if you look at the public health department, there's really not much for patient education here. There was in Clovis. I was in a class with a health educator from La Casa, and they phased her job out because it doesn't bring a lot of money in. It's hard to reimburse for. Medicare does pay for diabetic self-management education, but in the year that you're diagnosed with diabetes, they'll pay for 13 hours, and subsequent years they'll pay for 4. You can imagine how you live with diabetes every day. You only get 13 hours of education paid for, so it's not a whole lot, even if there are resources available. Yes. Okay. So I took a course online through the American Association of Diabetic Educators. And it was called ABCs of Diabetic Self-Management Education. Because I wasn't taught it in school. I don't know if you guys were. Like, what did we learn in school? We make care plans, and we know what to tell the patient. But really, truly, like self-management education, like, what do they do all day? How often do they check their blood sugars? When they check their blood sugars? I didn't feel like I knew, what I should really be telling my patients. So it was just it's called the ABCs of Diabetic Self-Management Education. And I went through and took the modules. I learned a lot. I really did. One of the big major things in the literature is that traditional education, to me, that's what we provide a lot on discharge. We give them a list. We say, don't watch your carbs, don't eat this, watch your salt, your sodium, and we give them those discharge instructions, and then they go home. Say we had a couple of patients come in that's when they're diagnosed with diabetes, and maybe we do return demonstrations with them, show them how to use the insulin, and that's okay, but that's traditional education. And it is absolutely, like I said, it's necessary. You have to give them knowledge, but self-management education takes it a step further, and it's about helping your patient figure out how the basics fit into their daily routine. A good place to start with your patient, and this can be just at the bedside, like while you're taking care of them. I found some articles that say it sounds like a lot because we already are pressed for time. It's busy, you have admits, you have discharges, it's inpatient care, it's busy, we get it. But it's supposed to not take you that much more time to do this with your patient. You can start by asking them about their concerns and their fears. Okay, that's a good place. Asking open-ended questions. And then talking about their routine with them. Like, what are they doing now and what are their goals? And that can be, it doesn't have to, you don't have to sit down and be there for a half hour, but as you are taking care of them, ask them, how often do you check your blood sugar? things like that. And you guys do that. But it doesn't have to be all at once. I am sitting down to do diabetic self-management education. It's just intermittent. Because if you think, so the 13 hours that they got covered by Medicare, you see them for 12. You see them way more than they see a healthcare provider for this stuff all year long. You know what I mean? And then self-efficacy, that's all about believing how, if the patient believes that they can do something, and they show that if they believe they can do something, then they will try to do it. And in your packets, there's a sheet for action planning. And this was, in the very front. So we did this every week with the My Chronic Disease plan, and I can make 1 billion copies of these. This was something that was recommended to do with inpatients because it's pretty quick, and it's just helping your patient come up with a small, obtainable goal, breaking things down into smaller parts. We had to do these every 6 weeks, and it's difficult to make changes. It's really difficult. I think I had a couple of weeks where I didn't meet mine, but it could be anything: increasing activity, eating more vegetables, things like that. But you have to be very specific about it, and it's all about what you are going to do, how much you are going to do. Like if you're I'm going to eat more vegetables. I'm going to eat 3 servings of vegetables a day. And then it says, when are you going to do it? On Monday, Wednesday, and Friday. And, when are you going to do it? Throughout the day. For what days of the week? Monday, Wednesday, Friday. So it's very specific, and it should be something that they feel confident that they can do. And that's just like your pain scale, confidence scale, 0 to 10. If they pick a goal that they feel like they are a 7 on the confidence scale, 7 or higher, that they can actually achieve, then that's a good goal for them. This is something, we could do it on discharge. It shouldn't take that long to do. You can sit there and help them do it. I don't know what you guys, and I want to hear your opinions, because it's frustrating. I think we see patients over and over again, and we don't feel like we're doing anything for them. A lot of it's looking at, they don't have resources available to them. How much does it cost? Like the test strips are ridiculous. Insulin is expensive. It's not that they don't want to all of the time. Sometimes they don't want to, and
we don't have the resources to pay for stuff they need.
Right. But what if we can help them do small things?
So we give them this form on discharge. Who follows up on it, or how does that go? Like, how are they gonna?
That's what I'm also working on, because I want this is an idea session. What if it was something, we do follow-up phone calls already, right?
Yeah.
We already do that. What if this was something that we asked? So just one question: how is your action plan going? Did you make a goal while you were in the hospital? How is that going? I don't want to add work. I know because you guys are busy and you do a lot. This isn't mandatory. I'm not making it, I'm not out to create something that this is going to be our protocol, and if you have a diabetic patient, I want to see this, 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 and this on your chart. But it's like almost like a moral thing. I feel as a nurse I should be giving my patients the best opportunity that I can, and maybe some are receptive to something like this, maybe some aren't. But this is just another tool that you can have, and we can talk about, making it, is it something that we should implement? If you think so and you're on board with that, okay, go ahead. And maybe it's something that we could make a note on those follow-up phone call sheets. Well, it's a good idea. But do you think it's something that you might try? Because
try it. I don't see why not.
We'll go over, we're going to make one before we leave. I want to make one before you have to leave. To try yourself, because it was kind of enlightening. Like you said, you think it's something so simple, but it is difficult, and you have to actively try to change. And I think it helps give us a little more empathy with our patients. So.
Out of all the many patients that I have had in Florida, diabetic patients, only one was able to actually lose weight and
Yeah.
manage the
Yeah.
blood sugars and all the stuff, and that was because of Sosa. And part of I didn't follow up with her, but she's kinda friend
Mm-hmm.
kinda.
Mm-hmm.
So every time that we meet in Super Safe, she was buying vegetables,
Yeah.
and she is so happy now
Yeah.
that she can manage the blood sugar. But
What did you do with her? What was your?
I just told her that good for you, go ahead, keep doing it. But I actually didn't do anything for her.
Okay.
She was ready.
Right, and that is, you have to, yes, readiness or
Yes.
changes of each day.
Yes.
Yeah.
And the other patients, they have underlying conditions, depression,
Mm-hmm.
alcohol abuse,
Mhm.
and all this stuff, and I don't know
Yeah.
how that's gonna work with them.
Well, sometimes, and that's right, and that's, some people are gonna like fill it out and they're gonna be, oh yeah, and then they'll come back, they'll probably call you, Nelda, guess what? But then you get those patients, so the underlying depression is a major thing that they bring up here. So what if that is something that we address before we even address diabetes? Like that's really the barrier that's keeping them from achieving anything with their blood sugar levels, their blood pressure, anything like that. What if, and I think a lot, this is me personally, I think that comes down to a conversation that you have with them, like, and figuring out like what's going on, you know, what has gone on recently, life changes. I know we asked that on our admission assessments. Have you had any major life changes? Has anyone in your family passed away recently? But it's dialogue, just talking to your patients, getting to know them, and I bet that is part of the, you would like Margaret Newman, but it's about getting to know your patient and seeing that there's more than what meets the eye. And I think maybe that's a place to start. Maybe that's, and you're right, maybe they don't need this when they leave. They need something to help with their depression.
We don't really have any site consult capability.
We have Eva. We have, with this ECHO project, we have Eva. And if you want, if we need to get more brochures, if that's something that you want to give to your patients, I'll do that. I'll work on that. 'Cause for being as small as we are and having this many patients, we have some good things going on. And I'll get on that.